The other study due to start also October 1, so that every IPF Net Center come October 1 will have a trial for any IPF patient essentially, is the ACE trial looking at anticoagulation evaluation of pulmonary fibrosis. And this is based on the Kubo study that I mentioned earlier that improved mortality with the use of anticoagulation. The problem with that study, well, there were numerous problems with that study. Patients were on Coumadin and received aldaparin in the house, but how truly randomized it was is a subject for debate. And as I've already mentioned, the Japanese group may be slightly different. But with that kind of strength of data in what was a small study of 54 patients, we felt that there was enough robust scientific data to pursue a multi-center randomized double-blind placebo-controlled trial looking at a composite endpoint of the things that we thought anticoagulation would affect. I don't expect anticoagulation to necessarily affect decline in FVC alone, but I do expect it to perhaps affect that as a surrogate for other activities such as mortality, hospitalizations, and then we're using that decline in FVC because of the strength of its data in regards to those two other pieces, so that we can limit the time of the study and have a more efficient design. The inclusion-exclusion criteria, incredibly simplistic. A sure diagnosis of IPF, as all of these studies require, any FVC, or any DLCO. The obvious contraindications, you can't already be on Coumadin, because then you're not getting randomized. And you can't have a concern that putting you on a blood thinner would create higher risk. So in my last 2 minutes to finish up, since there's no approved therapy for IPF, I'm a firm believer, and I preach this very loud in clinic, that patients should be encouraged to enroll in a clinical trial, because that's the only way we're going to continue to answer these types of questions. So which types of patients should be enrolled? My opinion, if they meet criteria, although I will freely share that I have a number of patients who come to me who tell me the following, and I find this to be mind-boggling, but I've learned to accept it. There's no fighting it. I would rather be on nothing than a placebo-controlled trial. Failing to see the irony of that particular statement. But when I get that statement, I back off, we focus in on the other elements of the disease that we can treat, and I let it go. And it's actually a significant number of people who give me that answer. What are the best primary endpoints? Well, that's still a subject for debate. But I think the strongest right now is still that FVC change. The 6-minute walk clearly has some value, but its biggest problems are a floor and a ceiling. Progression-free survivorship is still obviously what you're looking for, and an event-driven endpoint has a great deal of utility. And finally, mortality is still the biggest kahuna. Therapeutic management, I'm going to say this, my mentor was Larry Wood. He said, tell them what you're going to tell them, and then tell them again. Not everyone dies from IPF. So we should and must treat the comorbidities. Coronary artery disease. I didn't talk much about the lung cancer, but I have several patients that I have sent for resections of primary adenocarcinoma with cure. Right? They have a 5-time higher rate of lung cancer. If they can tolerate the resection, they should be sent. The nihilism that we often have seen for decades needs to disappear in the treatment of these patients. Just because they have the diagnosis doesn't mean they should be ignored. Pulmonary hypertension, I think you're seeing a growing body of evidence and focus of therapy for that. Obstructive sleep apnea, I think there's an excellent evidence base for that. I think the reflux is an interesting question that has to be explored further. And lung transplantation, I actually bring that up on almost the first visit. That isn't to say that every patient's a candidate. That's to say I want it discussed. Now, that's a very personal, important issue and has very strong feelings. And if a patient tells me they're not interested in transplant, they're not interested. But it's my job to make sure that they know that that's available to them. And then, of course, clinical trials. And I'll stop. Oh, sure. Wow. Already.
This is the question and answer period, and Dr. Noth has received your questions, and I'm sure we'll be happy to answer them.
Sure. But I'll take help from the crowd, too. Is there a male-female predominance? Oh, yeah. Well, Dr. Johnson showed you that earlier, that there's at least the literature cites, he showed 2.5 versus 1.6. I often quote 1.7 versus 1. I actually think that the more stringent the diagnosis gets, the male predominance is even stronger. In our clinic, I think it's about 3 or 4 to 1. So there is a clear gender difference. And I actually am suspicious that it has to do with the genetics and an XY thing. Can you elaborate on the dyspnea score? Absolutely. Scores are probably the best way to define a change, but I will tell you that the clinical trialists haven't been so rigorous. A lot of that data is born out of 2 different studies, one by Moises Selman and Naftali Kaminsky that took a look at change of sense of dyspnea over time. And the other was out of the BILD data set, or no, the NREL data set, that really just asked the question, do you feel more shorter breath this year than last year? Now, I tend to tease that question in clinic. And the way that I tease that question, because people who get shorter breath do less. And so the classic examples I always give with COPD is, did 18 holes of golf become 9? Did you quit mowing the lawn? Do you pay someone for that? You know, have you eliminated activities of daily living that you didn't appreciate subconsciously, even though you're telling me that you're not any more shorter breath? And I think that those are signs of that, and probably a much more practical way in clinical practice than starting to score everybody from the Borg. We score everybody on our 6-minute walk with the Borg anyways, and it obviously gives us some research data. Oh, what is meant by ground glass? Excellent question. First of all, it's that, I'm going to answer that in 2 parts. It's that Coke, the ground Coke bottle, the old, you guys remember the old Coke bottles, the glass ones? We don't have those anymore, but you know, if you find it on the beach, it's that ground look of that ground glass that we see on the CT scanning. And if you think back to the CT scans we showed, particularly in exacerbation, there's an image there of ground glass on top of that honeycombing. Now, ground glass almost universally represents either inflammatory cells or water. And so what it's telling you is it's more than just straight fibrosis. And that's why those patients, at least at current, often have an indication for a biopsy if the honeycombing isn't present. What is the relationship between Raynaud's and pulmonary fibrosis? Well, there's a $64 question that deserves some investigation. It's a loaded question I'm not going to answer entirely in the sense that we know that patients with autoimmune disorders, the collagen vascular disorders, have a higher rate of interstitial pneumonitis. That is UIP, which is the histopathologic correlate of IPF, and NSIP, or cryptogenic organizing pneumonia, or a bunch of others, but those are the 2 big ones. There's a current debate in the literature if a patient with IPF has Raynaud's, do they actually have something called an undifferentiated connective tissue disorder? In other words, we haven't been able to pigeonhole them in the proper autoimmune category yet, but is it belaying a systemic disorder, or is it just another manifestation of IPF, and that has yet to be settled? Jim, you would agree with that?